Association. I want to welcome you to our annual educational symposium. We are thrilled to be at this venue. This is we've certainly done this event every year, but this is our first time at this particular place, and we're thrilled, and we hope that you enjoy this as well. I want to welcome you all today, and please enjoy breakfast. It has been catered by Anne Marie's, and we will see them again for lunch. I wholeheartedly want to extend our sincere gratitude to all of the exhibitors and supporters that are outside those doors. They, as well as the volunteers who help plan this event, without them, we most certainly would not be here today. We wouldn't have this opportunity to join together, to learn, and to support one another. And we also would not be able to offer this free for all of our family caregivers. So I want to say wholeheartedly, if we can give them a round. I know they're all out there, but Dr. Weiss starting us off. But a few housekeeping things. If you'll please do us a favor and put your cell phones on vibrate, we really appreciate that. Also, the restrooms, when you walk outside, take a right and then a left. They're down that hallway. Also, we have asked all of our supporters to donate some gifts, which we have up front. And so throughout the day, we will be drawing for different prizes. We have a lot of different items. We have many items that haven't even quite made it up here yet. But more importantly, what we would like is for you to take a peek into the folders that we gave you at registration. And there is a program with thanking all of our supporters, as well as the packed agenda for today. If you'll do me a favor and pull out, there is a purple postcard that's tucked into your folder. And we are going to use that as your entryway into drawing for all of the prizes today. And what that postcard is our advocacy. In addition to all the things that we support and do through the Alzheimer's Association, advocacy is key to that because it helps us reach the key people that we need in order to fund research and to make Alzheimer's more of a priority. So what we do throughout the year is collect those cards, and even if you just filled one of those out, if we were lucky enough to have you at our Walk to End Alzheimer's in September, we may very well have had you fill out one of those cards then. We are going to ask you to fill it out again because it's an action. Every time that we turn those in to our elected officials, that's us back home saying, look, we need you to prioritize Alzheimer's disease. And they can't do it soon enough. And so you'll fill that out and leave it on the table with us, or we've got a drop box right up here. Meg, our director, is going to hold that up. So if you'll fill that out, there's also a sticker on the top. If you will peel that off and wear that all day, that represents that we are here as one voice for people with Alzheimer's disease and dementia. And we greatly appreciate your help in that, and we will be drawing all day for some goodies. Also, I want to thank, if you have any of the planning committee, if they're in the room or if they're in the hallway, if you would stand so we can acknowledge you. I think a lot of them are still, might be out in the hallway, but we most definitely want to thank our volunteers who, again, we wouldn't be here without them. Most definitely, we accomplish what we do through our volunteers. And lastly, I wholeheartedly want to thank the people that I am truly lucky enough to get to work with every day. Meg Barron is our executive director. You will be hearing from Meg later today. Nancy, who I hope you met out at registration, mentor, our guru, our expert. She talks to people every day on our helpline and has helped thousands of people along the way. Belinda, who was at Professional Check-In, Belinda is our walk coordinator and just incredible staff members to be able to work with. LSAO, who you will be meeting later today, he actually is based out of our Corpus Christi area because our chapter covers all of South Texas. So look forward to having you meet LSAO during the day. Marie is at our Alzheimer's Association table. I do hope that you will stop by and meet her as well. And most definitely, last but not least, she disappeared, I want to say wholeheartedly thank you to Maxine, who I am so privileged to be able to work alongside with in our programs and our advocacy in the office. She puts so much time into these symposiums that we do and just does a great job. So Maxine, wherever you are, she must have stepped out, but I wholeheartedly want to thank her. And I would love to introduce Joe Zapata, who is here from the UT Health Science Center Geriatric Education Center, who's going to tell you more about some of the paperwork that's in your packet that is important.
Thank you. Good morning. Again, my name is Joe Zapata. I'm from the South Texas Geriatric Education Center for the University of Texas Health Science Center here in San Antonio. And I'm the continuing education coordinator for this conference. And for those of you who are elected to have and obtain continuing education credits today, I'm going to walk you through some paperwork real quick. Located in your purple folder is the statement of attendance form. Now, I'm going to need you to turn this in to me at the end of the conference to receive continuing education credits. And I need the first page on the back filled out with the amount of credits that you are attending today, your signature, and your email address, because that's the method I'm using to submit and to deliver your continuing education credits. You should clearly select your CD type and have that turned in to me. Again, I'll be giving you more instructions of where I'll be exactly at the end of the conference, but make sure you have that turned in to me by today. Along with the paperwork is the disclosure forms or learning for today, and all the committee members and learning faculty who will be speaking today. And the other piece of paperwork that's also very important is the participant profile. This is a completely voluntary demographic profile that we use to obtain grants from the federal government to give learning sessions such as these for a low or free cost to learners who are willing to participate in this kind of educational sessions. So if you would please fill out as much information as you're comfortable with, so that then we can submit it to the federal government. And of course, all information you give to me is purely confidential. Won't be used for any other purposes as far as any education and grants provided. So if you have any other questions or concerns about the person profile or obtaining CEs, you can go ahead and find me. I'll be all over the place today, and you can definitely come to me and ask me questions you like concerning your profiles or continuing education or even about this today's educational activity. Now, I'd like to introduce
On the left-hand side of your packet, I did need to mention there are two forms that are there from the Alzheimer's Association. We too are in a situation where when we go to foundations or grants, when we write grants, it's important for us to be able to talk about who we serve, who our constituents are, and so there is an education sign-in sheet that we would ask for you, for everyone today to please fill out, and then behind that is a survey which we would ask you to fill out at the end of the day, and that one is just give us your feedback. We want to improve upon this conference and make it better every year, and so we really appreciate you taking the time to do that as well. And just one last thing. Again, we are extremely grateful that each one of you are here with us today. This disease, all of these dementias are
And the headline right now is Dr. Thomas Weiss. He is our first speaker of the morning. Dr. Weiss received his undergraduate degree at the United States Air Force Academy and his medical degree at the University of Texas Health Science at San Antonio. He then completed his psychiatry residency at Wilford Hall, United States Air Force Medical Center, and fellowship training in consultation liaison psychiatry at Massachusetts General Hospital. Dr. Weiss is board certified in adult, addiction, geriatric, and psychosomatic psychiatry. He currently conducts clinical trials and research for Radiant Research, which includes dementia treatments, novel anxiolytics and antidepressants, addictions, psychopharmacology, and cognitive enhancers. Please let's all welcome Dr. Weiss.
Thanks a lot, Valerie. I can't hold a candle to the wonder of that. That's an impressive achievement. It's just an honor and a privilege to be asked to speak on behalf of the Alzheimer's Association, an organization that I simply think is magnificent. And I think staff, all of them are angels here on earth. So I'll just leave it at that. I was trained by Jesuit priests, and they insist that before you do a presentation, you have to tell a story. They also insist that you introduce pieces of history, or I'll be struck down by a Jesuit lightning bolt. So I'll begin with a story and move quickly to the presentation. You heard about the nun who landed at O'Hare Airport and she hailed a cab. And as they were driving along, the cab driver kept looking at Sister repeatedly. And finally, the nun said, "Young man, may I ask why you keep staring at me?" And the cab driver was a little nervous. He said, "Well, Sister, I've had a lifelong obsession about nuns, and I wonder if I might ask you a personal question." And the sister said, "Well, you know, when you've lived as long as I've lived and seen all that I've seen, you can ask me anything you like." The cab driver said, "Is there any chance that I could ever kiss a nun?" The sister thought about it. She said, "Oh yes, it's possible, but you have to fulfill two conditions. The first condition is you have to be Catholic, and the second condition is you have to be single." And the cab driver had a big smile on his face. He said, "Sister, I am Catholic, and I am single." And the sister said, "Well, why don't you pull over into that alley and we'll fulfill your lifelong obsession." And they got back on the road, and a few minutes later, the cab driver started to shake and sweat and kind of burst into tears. And he finally blurted out, he said, "Sister, I have to confess to you, I'm not single, and I'm not Catholic. I'm Jewish, and I'm married." And Sister said, "That's okay. My name's Jack, and I'm going to a Halloween party." So why would I tell such a story on Thursday night? You know, we laugh, but the reason I'm glad with that story is, part of the reason we laugh is, that story's about some inappropriate behavior. That story's about some bizarre goings-on. That story's about some unusual judgment and decision-making. And I promise I'll do my best to point it into the presentation. So, what a title! I'm invited by the Alzheimer's Association to chat with you that the title said, "FrontoTemporal Dementia, it's not Alzheimer's." dementia. So I think they put me first so I don't confuse you for the rest of the day. Let's fire away, or I'll tell the GECs really fire away. Okay, so let's begin with this 4-pound organ that sits on top of our spinal cord. It takes 25% of our glucose every second of every day. The command post. And, you know, we're lucky to live in 2013 because we're really, step by step, trying very hard to understand this magnificent creation. But this is an incredible simplification of our brain. We're looking at 4 different lobes. The frontal lobe, which we think is, quote, the seat of judgment, decision-making, insight, inhibition. We're looking at the temporal lobe, perhaps the seat of memory and association. The parietal lobe controls all motor function. And the occipital lobe, visual interpretation and discrimination. What a just a fascinating organization to begin with. This beautifully choreographed and orchestrated instrument that works automatically for us, makes us who we are. So this is our ambitious proposal for the next 30 or 40 minutes. Please forgive me with those judgments overtrained me. I'm pretty sure we can accomplish all the objectives. And I promise at the end, I'll just wrap it up with 2 things. Because really that's all I'm ever able to go home with from any lectures. 2 things. So we'll do a little test just to put us on our toes. This is one of those questions that you get in medical school. It's not a multiple choice question. It's called a multiple, which means you really can't even guess, darn it. So the question is, which one of the following is true? Frontotemporal dementia is the second most common dementia in those older than age 65. Gotta read carefully here. FTD is best diagnosed with psychological or neuropsychometric testing. FTD patients have a shorter lifespan than patients with other diagnosed dementias. All of the above or none of the above? Darn, this is harder than Chinese trigonometry. So I want you to think about this one. I promise we'll give you the answer as we go down the line, but let me get the juices flowing, get us questioning things right out of the gate at 8:15 on a Thursday morning. So we're going to begin with a wee bit of history, and I hope you've all consumed your breakfast, because part of this might be a little explicit. This is the strange case of Phineas Gage, also known as the American crowbar case. So Phineas Gage was a railroad foreman working to build a line of tracks up in Vermont in 1848. He was a very hardworking, industrious, beloved foreman, although he was a young man. And one morning, he dug a hole, and he was tamping in an explosive charge to clear some ground, to lay some track. And he was tamping in the explosive charge with a bar of steel that was 3 feet 7 inches long and 1 1/4 inches in diameter. And this bar caught a rock, struck a spark, and there was an explosion. He drove this rod. You can kind of see a little bit of the picture at the top. He drove this rod through his cheek, out through the top of his head. even more miraculous, more incredible was he was awake and speaking. They transported him by a horse-drawn carriage a mile into town, where the local doctor attended to his wound, which was mighty. The bar was found 80 feet away from the location of the explosion, smeared with his blood and part of his brain. So as you can read, he was semi-comatose for a couple weeks, but slowly and surely recovered. Now this is one horrific injury, as you're about to see. As time passed, he made a full recovery, and he was later able to return to work. In fact, the last few years of his life, he was a stagecoach driver in Chile. He finally died 12 years after the accident, after he had a series of seizures, of fits. So, before the accident, as I described, this was a good man, sound, industrious, hardworking. After the accident, after he recovered, Phineas was different, dramatically different. He was profane, he was irritable, very unlikable, argumentative, complete personality shift. I love how they write. Described as a child of intellectual capacity, but with the animal passions of a strong man. You can almost sense this dramatic 180-degree personality change. So back in that day, there was a type of medical professional called a phrenologist. They would feel the bumps on our head and come up with diagnoses. And I love how they describe what happened to Phineas. They said that this severe trauma that he sustained damaged his organ of veneration and also damaged his organ of benevolence. It's beautiful terminology in the 1800s. Now, this event caught the eye of medicine in those days and continues to catch the eye of medicine. In fact, Phineas's skull and his iron tamping rod is in the Harvard Medical Museum. And the reason it caught the eye of medicine is, number one, this human being survived this most unbelievable catastrophe. Not only survived, he recovered. And it really kind of challenged everything we thought about brain injury in those days. The second piece is, he recovered. Of course, the wonder is, how did he recover? One of the ideas that's been put forth is that it's called the social recovery hypothesis, that you figure out how to compensate for his losses, and you figure out how to live. But what's remarkable is, when people go back and look at Phineas Gage, that change in personality, as they explore, it appears that that change in personality wasn't permanent. It couldn't have been permanent. There's no way this gentleman could have driven a stagecoach over the mountains in Chile the last 6 years of his life if he was the kind of beast that he's described after the accident. So, I want you just to think about Phineas, maybe the one thing you'll take home today. Golly, Dr. Weiss told me about the most horrific accident of a fellow in the 1800s, and he survived it. So now let's flash forward to 2013. And here's a wee case study. It's pretty short. Here's a 50-year-old gal, a young puppy in my eyes. I'm 61. And she's been a good worker, a good hard worker in her place of business. But in the last 2 years, something's going fishy. She's not able to concentrate as she once was. She's having trouble finishing tasks, and she was always an on-time gal. Overall, she's just a lot less responsible. Her office mates note that she's binge eating, and she's always been, pretty careful lady with food. She's hyper-oral. In fact, if she's not binge eating, she's often putting objects that you can't eat in her mouth. She's gained a lot of weight quickly, in the wink of an eye. Now, she's always been kind of a quiet, soft-spoken, sweet lady. All of a sudden, she's telling lies, dirty jokes, behaving in the most unprofessional and inappropriate manner. She picks up items compulsively, over and over and over again. Picks up a cup that's empty, brings it to her lips, puts it down. Her hygiene starts to go way downhill. This isn't just for a day or a week. She doesn't bathe anymore. Finally, she gets brought into the doctor for an examination. And the doctor does a number of things, a history, physical exam, hopefully takes collateral information from her family. But you'll notice at the bottom, and I know most of you in the audience are familiar with that abbreviation, MMSE, that's a mini mental status exam. It's kind of a quick, often ready test that physicians and clinicians do just to get an idea of how somebody's functioning cognitively. Their orientation to time, to place, their immediate recall, their delayed recall, their concentration, their language skills. Can they name? Can they repeat? Can they read? Okay? And a perfect score is 30 out of 30. Anything less than 25 begins to suggest a dementing process. Well, golly, this young lady does pretty well. She's 29 out of 30. Okay? The second quick and dirty office test that clinicians do to kind of get an idea about how someone's functioning is the clock drawing test. It appears simple on the surface, but it goes like this. Please draw a circle. I'd like you to pretend that circle's a clock, so now put the numbers around the circle as you would on a clock. And would you please put the hands on this clock to indicate the time, 20 minutes after 11. And as simple as that sounds, it actually requires a lot of processes amongst those 4 lobes of the brain that we saw in slide 1. You have to remember and know where the numbers go, and you have to sequence it. You have to remember that the shorthand points to the hour. The long hand points to the minutes. There's no 20 and 12 number clock. So it really requires a lot of insight, judgment, abstracting ability quickly. The clock drawing is awful. So we've got a mismatch here. Bit of a mismatch. So remember this sweet lady in 2013. Okay. The Jesuits always insisted that whenever you talk about anything, the first order of business is you have to define it, definition. So this is long-winded, FrontoTemporal Lobar, meaning we're talking about the frontal lobes and the temporal lobes. You saw it on the first slide. Okay? This is a degenerative process, meaning a slow but steady decline. That was described more than 100 years ago by a physician, Arnold Pick, in Europe. And quite simply, he said, this behavioral syndrome is associated with atrophy, with loss of tissue in the frontal and temporal lobes. We think there's 3 variants of this disease. There's actually 8 subtypes, but 3 major variants. And for today's discussion, we're just going to zoom in on the first one. The first one is the behavioral variant or frontal variant. begins with dramatic personality changes, not memory changes. Not memory changes. And in medical school, they call that, a foot-knocking step because that's going to be on the test. So this illness begins with personality changes. Okay? Memory is preserved. The second variant is kind of fancy. It's called the semantic variant. This has to do with language, particularly impairment in naming. Okay? In naming. And the third variant is another type of language disorder. It's got lots of names. The one that I was taught was primary progressive aphasia. And this has to do with expressive language, not just naming. And it's more localized to the left side of the brain. The second variant is actually on the right and left sides of the brain. But we're going to zero in on the behavioral or frontal area. So let's see what that looks like. Okay, first order of business. This is insidious. What a powerful word. It's so slow, you don't even see it coming. Okay? This isn't a freight train. This is a Chinese water torture, death by 1,000 cuts, eh? It generally announces itself with a change in behavior. But in our society, when people have changes in behavior, especially when they're in midlife, the first thing we're going to do is say, must be going through a midlife crisis. Okay? Second thing, we might say, maybe they're abusing substances. Third thing, maybe they've got some type of psychiatric illness, like depression, post-traumatic stress disorder. Okay? So, right away, you can see how frontal lobe dementia, FrontoTemporal lobe dementia, can frequently and easily be misdiagnosed. That memory problem that kind of characterizes Alzheimer's disease is just not evident, particularly early on. So then we start to see some changes that are things that we're immediately going to say, that's quite odd. Perseveration is one of those $10 words that means one says or does the same thing over and over and over again. So I'm old enough, some of you in the audience are old enough to remember a broken record. So you play your record and the needle would stick and the lyric would repeat and repeat and repeat until you got up and moved it. So we know that with this illness, and the frontal lobes in particular, that part of us that says, this task is done, we can now move on, doesn't register. Okay, so we keep repeating the same words and the same behaviors over and over again. So my dad was a gentleman of the old school. When he would meet a new lady, because he was a European guy, he'd often kiss their hand. He was a veteran, and he'd often salute the flag. Okay? But if my dad began to kiss everyone's hand, kiss their hands 10, 15 times, and if he began to salute every flag, big, little, then we'd say there's something quite afoot here, wouldn't we? So the fourth bullet, behavior changes, apathy. Apathy. In other words, the things that we love, the things that we delight in, it's all gone now. Just apathetic. And then there's that unrestrained and inappropriate social conduct. You saw it in that gal at work. Okay? I had a patient who was a strapping male. When he'd enter any public place, he'd loudly declare, I haven't killed anybody yet today, several times. Okay? His wife, who was extremely ingenious, finally created 3x5, little calling cards. It simply said, My husband has a terminal illness called FrontoTemporal Dementia. Please understand and forgive his verbal outbursts, which I thought was just such a clever, ingenious idea. So again, memory loss not prominent. I think that's the third time I've repeated it, so we got to have that take-home message. And therefore, the screens that we do for Alzheimer's disease may miss these poor souls. And then there's a little answer to our quiz. This is the second most dementing illness under, there's another knock, under the age of 65. So this is an illness that strikes patients when they're younger, not older. Okay, I think I've covered this ground, but you can see how this illness is very poorly misunderstood, frequently misdiagnosed. It's said that these patients often see 4 or 5 psychiatrists before they get appropriately diagnosed. So this is a little screening device that was used in a research project. Kind of gives the idea about some of the odd behaviors that these patients do motor-wise. And as you kind of scan it, you can just imagine sitting with somebody that has these behaviors, these motor behaviors. It would be unsettling to say the least. But wait, there's more. These are some compulsive behaviors. And you know, compulsive simply is a $10 word for doing the same thing over and over and over again without being able to stop it. And typically, compulsive behaviors come with obsessions. In other words, thoughts, intrusive, unwanted thoughts that drive these behaviors. In FTD, these compulsions don't have any obsessions. There's no thought behind it. It's just a compulsive behavior. You know, there's some of those pieces, and what you have to put in front of this is they're doing these behaviors not 10 times an hour, but 100 times an hour. So, I thought we fixed all of our my typographical errors, so forgive me. Some epidemiology, fancy talk for who gets this illness. We know that patients with FTD, half of them, have a family relative with a dementia. And you know the 4 most common types of dementia: Alzheimer's dementia leading the pack, vascular dementia, the dementia of Lewy body disease, and FTD. The onset, as I've emphasized and I'll re-emphasize, is in the patient's 50s. It strikes a full decade or more earlier than Alzheimer's dementia. So we're looking at a younger patient. And that means a younger, healthier, stronger patient that doesn't fit in an Alzheimer's unit where patients are older, frail, very vulnerable. In fact, these patients don't fit any place because they're misunderstood. It's difficult to find placement for them. And we think maybe this is the blessing. It currently affects 50 to 60,000 Americans compared to 5+ million with Alzheimer's dementia in this country. It's a drop in the bucket. But it doesn't mean that the suffering for the patient and the caregiver is any less. So a little more fleshing out here. Again, the most common subtype of FTD is the behavioral variant. You heard a little bit about the language variant, and there's actually some motor variants, but they're rarer still. Average age of onset is 52. More males than females, that's a mystery, don't know why. And the course from diagnosis to death, 2 to 20 years, but generally passing within 8 years. So a little more virulent, a little more passage to the next life in shorter fashion. So a little summary statement will kind of compare and contrast this to Alzheimer's dementia. We rarely will see this in somebody 75 and older. This is a disease that appears in the 50s. Behavior problems, early and common. Memory problems, much less so. You will see some memory troubles later in the course. Language, often very common. As these folks become more and more apathetic, they also become more and more silent and mute. This apathy isn't just for behavior and interest, it's also sort of apathy for language. Motor signs, these patients will have primitive neurological, what are called frontal release signs. These are signs that we see when we're born, and they disappear as our neurological system matures and evolves. But in these patients, it's almost like there's an unwiring, and we see these primitive neurological frontal release signs. Mood. So remember Phineas Gage, irritable and apathetic. What a curious and horrible combination. They're generally very withdrawn. They have no insight. And these are people that had insight. We don't think much about insight, but it's controlling everything you're doing right now in terms of how you behave. It's almost a motor that's running all the time. So, after this is over, I'm going to be a pallbearer in the funeral. And, that's when our insight is keen, because we know everybody's suffering and we comfort them. But with this illness, there's no recognition of that internally, and there's no recognition of that externally. Psychotic symptoms, relatively rare. When we see them, they're usually very bizarre. Sometimes they're religious, sometimes they're persecutory, but they're usually just flat out bizarre. We don't see those intruder, misidentification, perceptual disturbances that we see in Alzheimer's dementia. And then appetite, another maybe foot stomp or bell ringer. For, again, mysterious reasons, these patients, usually in mid and late course, become very oral. Okay? Perhaps that's part of this infantilization, putting things that one shouldn't put in their mouth. They have massive carbohydrate cravings. Sometimes family members have to put a padlock and chains around the icebox and lock the pantry. So, in the elderly, the challenge always when a patient presents with changes in cognition, changes in behavior is, what is the diagnosis? So, a few years ago, a patient teased me and humbled me all at the same time. She said, you doctors, you're just plumbers. You just diagnose and treat. That's all you do. And darn it, she's right. We're just plumbers. We just diagnose and treat. But before we can treat, we've got to diagnose. And it becomes very challenging in the elderly. Is this a neurodegenerative disease? Is this a psychiatric illness of some sort? Is it both? Is it neither? Is it a medical illness mimicking or masquerading? Is those it's tricky. And then in particular, if someone's been a very steady, reliable, good citizen all their life, and now you see personality changes, it's pretty straightforward to say the first thought that crosses the board is that this is psychiatric. It must be psychiatric. So again, these patients are frequently misdiagnosed. This illness is poorly understood. So what's somebody to do about that? Well, the good news is we've got lots of instruments and tools to help us, thank goodness. We now do some staging. This is staging based on history, physical exam, laboratory workup, and imaging, okay? And we can say this patient definitely has FTD, okay? It's usually done after a really thorough workup that involves lots of different tools, and I'll put those on the board in the next slide. We can say, we think they have probable FTD, but let's get a very specialized imaging to hopefully confirm it. And then lastly, and this is the one that I'm mostly operating in, maybe this is provisional or possible FTD. We need to get some more testing to hopefully confirm it. We need to get a better picture. So here's some imaging, okay? So the lovely world that we live in now, where we have the type of imaging where we can actually look at glucose uptake in our brain, and that's the primary fuel to run this 4-pound command post. And we know that when areas of our brain are damaged or killed off, that the uptake is impaired or absent. And it means the brain is cool when we run a particular type of imaging called a PET scan, and we introduce a tracer dye that has glucose in it. So when the brain is warm and running well and metabolizing glucose, you'll see yellow and green and red areas, and when it's cooled off, it'll be blue. So this is a patient with FTD in their frontal and temporal lobes. It's sort of like the Arctic, it's cooling off. Again, all patients that we're concerned about a dementing illness, we begin with and we end with a thorough history. And I always begin with the history from the patient, even though I know that might be minimal, that might be difficult to obtain. That's the first order of business, and then the critical history, the more comprehensive history, usually from the caregiver, the spouse, the family member. The physical exam is vital, with a very careful neurological exam, mental status exam testing. We hinted at some of those. We want to do a thorough physical exam, including toxicology, to rule out any possible physical causes that might be accounting for this behavior change. And then, if they've never had an imaging study, they deserve at least one right then and there to kind of get a look at the anatomy and the structures. It's lovely if we can get neuropsychological testing. That's often a matter of cost and access and coverage, but it usually is very helpful. And then, believe it or not, in 2013, particularly in research now, we're often asking patients if they'll be so kind as to allow us to do a lumbar puncture to obtain a specimen of cerebral spinal fluid. Now that isn't easy and it isn't fun. And of course, the patient can decline or consent. The reason we're doing that is this is actually a pretty good, not perfect, good biological marker of those abnormal proteins that are often seen in certain types of dementia. It gives us a leg up on diagnosis. This would be the gold standard, perfect world, unlimited resources workup. Okay. By the end of this, I'll have this mastered. So, this is dramatic. This is the type of imaging that from across the room one could make the diagnosis. I'm sorry I don't have a got a definition of the illness. We have a picture of what it looks like. We know where the damage is occurring. We know how this is different from Alzheimer's dementia. So back to our plumber analogy, we have a diagnosis and how do we treat it? Well, I just gulped because we have no cure. That's gravely disappointing and very sad. But hope springs eternal. We do have interventions. Of course, doctors, their first reflex is medications. So we have some pharmacologic medicines that have been used in FTD. They're helpful. We have a class of antidepressants, the SSRIs, the selective serotonin reuptake inhibitors. I can only say that once a day. These are medicines we're very familiar with. They're quite popular. Prozac, Zoloft, Paxil, Luvox, Lexapro, Celexa. They are helpful in terms of dampening repetitive behaviors. Those medicines are used in obsessive compulsive disorders to reduce compulsive behaviors, to dampen intrusive obsessions. So we think that they can be of some mild benefit in terms of reducing compulsive behaviors, reducing some of the inappropriate behaviors. So they're helpful, mildly helpful. Antipsychotics, or in my world, the heavy artillery. I don't think these medicines should be used unless all else has failed. And this is for patients with FTD that, because of the progression of their illness, their irritability, their impulsivity, their bizarre or inappropriate behavior has now become threatening or aggressive. And more than problematic, it's just flat out become dangerous. So these medicines are major tranquilizers. They're emotional restraints or handcuffs, if you will. So these are used in those particular scenarios, hopefully gently, hopefully at the lowest dose, hopefully for the shortest amount of time. Wow, this thing is incredibly sensitive. And I do apologize. Okay. So mood stabilizers, these are medicines that neurologists use to treat seizures, and psychiatrists plagiarize them and use them to stabilize mood swings. There's been some anecdotal reports that they might be helpful, but again, this is just vague case reports. The cholinesterase inhibitors, a fancy word for Aricept, Exelon, Razodine, 3 of the 4 medicines that the FDA has approved to treat Alzheimer's dementia. There's reports that these medicines can again dampen behavioral symptoms. There's also a very alarming case study where a patient with FTD who began Aricept became much worse very quickly. So again, proceed with caution. So we don't have a lot of tools in our black bag. So what's a patient, what's their caregiver to do? Well, again, in a perfect world, unlimited resources, unlimited access, this model would be lovely. There's a physician or a clinician who's at the patient's service. There's a health educator, because these illnesses are mysterious, to say the least. We don't get an instruction manual with them. We'd like to know what the future holds. That's why I'm such a fond believer in the 36-hour day, that wonderful book by the doctor and nurse. It's the roadmap to Alzheimer's dementia. And again, in a perfect world, actually, this and sometimes far more powerful than medicines. So what do we have here? Well, the usual suspects, but apply them to the template of frontotemporal dementia that you just heard, okay? These are patients that have behavioral changes, they have language changes, they have apathy, they have hyperorality. So just common sense directs us to, let's get a speech therapist in early and quickly. Let's preserve what we have as long as we have until we get some better treatments and medicines that maybe halts this or reverses this. Let's get a look at diet right away. And let's have a dietitian help us. Again, this is a perfect world. Exercise, well, the evidence is abundant now. I'm singing this song. We know that exercise is not only great for our heart, it's great for our mood. Okay? We even know the dose. The dose is at least 4 days a week, for at least 30 minutes. Or at the end of 30 minutes, you're sweating, however you come by. Okay? And let's not discount planning for incapacity. These folks are in their 50s. They're at the height of their workforce powers. And now, they're out of commission. So we've got to hustle up here. We've got to make some arrangements. We've got to put things in place. The first time I was told as a geriatric psychiatrist that I had to wear a lawyer's hat, I was repulsed at that idea. But I'm not any longer. It's part of my duties to the patient. We've got to get in order right away. Will, power of attorney, guardianship, advanced directives. We want to talk to the employer about disability. And we want to do it yesterday, not when it's a crisis or we have to scramble the jets. So counseling, driving. So these folks don't have problems getting lost. They have problems driving like my 16-year-old son used to drive, recklessly and impulsively, and not paying attention to timing. Okay? And then lastly, the caregivers of these poor souls, they suffer mightily. They suffer mightily. We think that their burden may even be a notch or two above that of Alzheimer's patients. Because again, these folks are young and strong and at the height of their powers. They require a lot of support. We're identifying some genes that may help us in the future. There's a trial with a very unusual medicine underway to treat this illness. Etanercept is a tumor necrosis factor medicine. I can only say that once a day. It's a very unusual way to treat this disease. Stay tuned. So, post-test. Got 5 minutes here. We got 2 slides up. They might be the most important. Psychotic symptoms are common in FTD. Memory impairment and personality behavioral problems are common in FTD. Misdiagnosis of FTD is rare. All of the above? None of the above. I suspect you already know the answer to this one. So, resources. When I finish, I'll leave this up. But there's some magnificent resources, and they model Alzheimer's Association. The Center for Excellence in the United States is at Johns Hopkins in Baltimore. And Dr. Chad Oniki, a Nigerian Hopkins-trained neurologist, is really the guru in this country. The Association for Frontotemporal Dementia, AFTD, is magnificent. It was started by a woman whose husband had the disease, and she kind of built it from nothing, and it's just a beautiful, beautiful resource. It has a very poignant film called What Is This? It's powerful. Family Caregiver Alliance, Utah, those good folks out in Provo, Utah, University of Utah, We have a cognitive disorder center there, another center of excellence. And we even have a 1-800 memory study line. So we'll go back to this one. So the last slide, this is from Dr. Oiki, trained in Nigeria. Not a lot of first world medicine there. Now, I'll read this to you, although I know we all can read, but I just like reading it because I like how it feels. He says, I never knew the main role of medicine as providing a cure. I came to know it as a way of providing clarity, comfort, and guidance. And if you're fortunate, a cure. If a cure is available, you only walk a short way before you and your patients shake hands. With FTD, you walk a longer distance, sometimes the whole way, with the family. So you already know about this guy just from this quotation. You know who he is and how he is, okay? I think this kind of sums it up. So I'm at 9:08, shame on me.